My name is Lila McDowell. I'm the Development and Communications Coordinator at the Prisoner Reentry Institute here at John Jay College. I want to welcome you to this morning's occasional series on reentry research session. We have a wonderful panel for you this morning. I'm so excited to have all of these amazing speakers sitting together at this table. And we're fortunate enough to have Probation Commissioner Bermudez moderating today, so I'm sure that you'll enjoy that. The bios of everyone you see here are on your program. If you want to check those out. And I want to encourage you to pick up a copy of this here, the Intimate Partner Violence, Prevalence, Effects, and Promising Interventions Annotated Bibliography. One of Dr. Gilbert's students, Tina Jawatram-Negron, put this together, and it's a wonderful, wonderful resource. So one of the things we love to make these available to people, to audience members at these events, so that you can take them away and find out more. So without any further ado, I'm going to introduce Commissioner Bermudez.
Good morning, everyone. Thank you very much for having us here, as this is a very critical and timely panel, certainly for us. Because we need to figure out how to best address the issues of IPV. We at the Department of Probation are trying to become the agents of what works in a non-clinical setting, building an evidence-based practice that is grounded in research and in the experience of all of you experts on the field and the experts on this panel. This is an issue that we take very seriously and that we're monitoring closely. Just to give you a little sense, from 2013 to 2014, we saw a 16% rise in the number of domestic incident reports we received from the NYPD at probation. And you know, as part of our work, we try to hold offenders accountable and keep victims safe. But it's not so easy. This is a very complicated dynamic that we see. And let me say something a little something about language. If anybody can figure this out, I'd love to hear some ideas. There are terrible language issues here. Offender, batterer, perpetrator. Who wants to be called that, right? On the other side, victim, battered woman, you know, and even things like harmed party doesn't address it because it's not just one person, right? This is a family issue as much as it is an individual, you know, two-person relationship. So anyway, so those are things that we struggle with because we have found in our work in the justice system that humanizing what we see and the behavior we're trying to change and the people we work with is critical to our success. And also because the line between offender and victim shifts, right? One can become the other, and there are often a host of other issues and stressors in a person's life related to the violence, drug use, criminal justice involvement in general, trauma. So we look forward to learning from you about how to approach our clients, be they victims or offenders, in a holistic and hopefully effective way. So let me introduce these experts and explain the format for today. Dr. Gilbert will present, and then the panelists will discuss. We'll have some discussion, and we'll save time for questions from the audience at the end. Our main presenter is Dr. Louisa Gilbert. She's associate professor at the Columbia School of Social Work. She's a licensed social worker with 25 years of experience developing, implementing, and testing multi-level interventions to address HIV/AIDS, substance abuse, trauma, partner violence, and other co-occurring issues. For the past 7 years, she has collaborated with the New York City Department of Probation and the Center for Court Innovation on several research studies to advance evidence-based interventions that may best address the problems of substance abuse, violence, and HIV in community supervision settings. Our panelists are Brenda Davis, which I am especially proud to introduce, and who has been at the Department of Probation for over 30 years, rising through the ranks to become branch chief, which is an administrative position that she has held for 14 years already. And she's currently in our Bronx Neon, which is our neighborhood opportunity network, a community, sort of community probation, if you will. She's helped us develop our own homegrown and successful PACT, Domestic Violence Program, which stands for Promoting Accountability and Community Ties. a collaborative effort among the New York City Department of Probation, Safe Horizons, and the Bronx District Attorney's Office. Aruna, I'm going to try to pronounce everybody's name correctly. Krishna Kumar, is that correct? Is a supervising counselor at the Hedrick Martin Institute, where she provides supportive counseling to LGBTQ youth ages 13 to 24 around mental health, substance use, HIV care, gender and sexuality, and family relationship issues. Then we have Virginia Lasowski-Nepa, Senior Director of Programs overseeing treatment services and family services at the Fortune Society. Before that, she spent years at the Women's Prison Association working on a wide variety of reentry issues. And Lori Leach, Director of Threshold Global Works, and she is a practicing psychotherapist, clinical trainer, consultant, and researcher who will address the issues from a neuroscience perspective. So, without further ado, Dr. Gilbert.
Thank you so much, Commissioner Bermudez, and most importantly for your vision and leadership on this issue. And I really want to thank the Prisoner Reentry Institute and Ann Jacobs and Rebecca Hockman for spearheading this whole idea of getting everybody together. Let me just get this started. Today I will be presenting just to give you a quick overview of my talk. I'm going to give you sort of a brief overview of sort of the scope and severity of intimate partner violence and really try to funnel it down to what does this look like among folks under community supervision, particularly focused on women under community supervision, but we do need to focus on men as well. Just look at the continuum of multi-level interventions that we can use to address this issue among in community supervision settings. And then also looking at some of the findings from our own IPV intervention research in probation and community courts that we've been doing since 2008. So just to get us on the same page, I know you guys are so familiar with intimate partner violence, but just to go over the domains, it's a constellation of abusive and controlling behaviors that include psychological abuse, sexual coercion, physical violence, and I have to say the newer definitions of it include financial and economic abuse. Now, how many of you in this room, when you think of that, you think of a woman as a survivor and the male as a perpetrator? Yeah. I mean, that usually, I just want to say that this is something that's always in our heads, and I'm trying to always deconstruct in my head, and I want us to sort of really think about all wide range of relationship, women as the perpetrator, male as survivors, same-sex relationships, and just really try to mix it up. And something that varies culturally tremendously and covers a wide range of romantic, dating, sexual, and marital relationships that go from adolescence to the elderly. There was just a case in the New York Times, I don't know if you read, about a case of an elderly couple in a nursing home where the man was charged with sexual assault because his wife could not consent. She had Alzheimer's. So, I mean, these are very, very complicated issues. And I have to say this presentation will focus mostly on women survivors. Luckily, we have Branch Chief here who is going to be talking, I think, more about the restorative justice, and other folks will be talking about what does it look like for perpetrators. And as the commissioner said, it's often both, and we need to keep that in mind. There we go. So just quickly, 1 in 4 women and 1 in 7 men in the U.S. will experience severe physical and sexual IPV in their lifetimes. That's really just all about us. If we know our friends and families, we know somebody in this situation if it's not ourselves. And every minute, 24 people in the U.S. are physically or sexually assaulted by a partner. Every day, 3 women in the U.S. are murdered by a partner. And each year, 12 million women and men experience IPV. This is a huge epidemic. Why is this not going? Okay. And so the cost of IPV, I was recently at a conference where Sir Michael Marmot, who is knighted by the Queen for his incredible work on health inequalities, said, you folks in America are great when you want to decide to address an issue. So what did we do? We mounted a huge effort on Ebola. We spent close to $1 billion on Ebola when we knew that that was a threat. And we had to struggle to pass the VAWA Act with $79 million. So just to put it in perspective, IPV costs $8.3 billion in expenses annually, and that's just the higher medical costs and lost productivity. It does not count the cost of all the criminal justice related costs, from policing to community supervision to jail, all of that. There was a recent Canadian study that put it at about $15,000 per year. I don't know, you folks at John Jay could probably do this much better than we could, that's not my area, but I think it's important to acknowledge. So just in terms of just what do we know about multi-level risk factors for IPV, first and foremost, probably drug and alcohol use by either partner, younger age of women and partner. We're really targeting groups from age 16 to like 24. This is the highest risk age group, yet we know least about it and there are fewer interventions for it. Pregnancy is a huge risk factor. Criminal justice involvement of either partner, mental health problems, trauma history of either partner, and witnessing partner violence. Boys who witness their parents perpetrating violence are like 5 times more likely to perpetrate it themselves, and girls are about 4 times more likely to experience it if they've seen it. So we need to get it early. Will continue. So the other thing, the more recent research that's been very interesting and illuminating is looking at community macro level risk factors, and really with some of the geocoding work that's going on now with GIS, we're seeing that neighborhood levels of violence, incarceration, poverty, education, and employment are all strongly associated with IPV. So we really say zip code is more important than your genetic code here. So this is a study that was done by a Columbia Mapping Project, but this was kind of what was born, I think you folks in probation probably know it much better, was men admitted to prison. You see it really clustering in certain neighborhoods, and these are all the low-income census neighborhoods, which really sort of informed the whole place of where do you put those neighborhood employment opportunity networks. This was a brilliant idea, I think, that probation has taken. But the Office of Domestic Violence has also looked at this very carefully, and what they're seeing is that family homicides are much higher in neighborhoods. This is the neighborhoods with the lowest socioeconomic census tracts. Poverty levels are, compared to neighborhoods overall in the New York City population, 40% higher in the neighborhoods with highest poverty levels. Same thing with lowest employment levels, it's much higher, and lowest educational attainment, and lowest median household income. So we're seeing a convergence of these concentrated epidemics by neighborhood. And just to look at it, what do we know about in the criminal justice system? Well, we know that 57% of women in jails and prisons have reported ever experiencing severe physical or PV. 37% have experienced a rape at some point prior to their incarceration. 89% of women in prisons who have reported any IPV also have a history of drug use. So we really see the syndemic intersections between drug use and IPV, which I'll go into a little bit. And IPV, we know, and you all know who work in these community supervision settings, is a serious public health problem. On the uptick in the incidence, I hadn't realized that, is very interesting and very, very disconcerting. It disproportionately affects women under community supervision. However, there have been no population-based studies of IPV that we know of in community supervision settings. So I think that that's something we really need to work towards, because that is our roadmap moving forward. We need those epidemiological studies. So women are the fastest growing segment of the criminal justice population, 85% of whom are under community supervision. And just to show, approximately between 45 and 55% of women under community supervision report using drugs and are at very high risk of intimate partner violence. Past year rates of intimate partner violence among women who use drugs or misuse alcohol are about 3 to 5 times higher than rates in not normal, but in community-based or population-based surveys of women. And then there are also a lot of research showing strong bidirectional relationships between different types of drug use and different types of violence. And really have to say, if we don't address that issue of intimate partner violence, among justice-involved women is likely to result in much higher rates of relapse, recidivism, and re-victimization. So there's this endemic going on between drug use, IPV, trauma, and recidivism, and we need to figure out the biological, behavioral, and structural links that are creating this endemic. In terms of current approaches in the criminal justice system, rates of recidivism in most perpetrator and survivor-focused treatments are approximately 20 to 30% within 6 months, regardless of the intervention strategies. Right now, we're not coming up with too many effective strategies, and they're actually higher among survivor-focused interventions, women who've gone through it or men who've gone through survivor-focused. So some preliminary evidence, and it's very preliminary, it suggests that couple-based interventions to address IPV significantly reduces the likelihood of recidivism where there is mutual IPV going on. That's an approach that I think has been sort of, for philosophical and political reasons, that a lot of people have held back on moving forward with couple-based. But if it is mutual IPV, I think we need to think about that. And then the other, there is some special evidence suggesting that specialized IPV units in probation departments significantly reduces the likelihood of recidivism among offenders, and this is particularly in the state of Rhode Island that has piloted a program with that. So what we're looking at is how can we go out? I mean, the community supervision settings represent a great opportunity to actually go out because because so many women are at risk, and you're precisely serving those neighborhoods where these concentrated epidemics are, and identifying women who are experiencing IPV and linking them to services. And screening there are just emerging IPV screening, brief intervention, and referral to treatment service models, one session kind of case management where you screen, you do a brief psychoeducation, and link them to services that are effective in healthcare settings. They have not been used outside of healthcare settings. There's also some evidence that you can start doing this as computer self-paced IPV screening models have been found to increase disclosure of IPV in healthcare settings. So we're looking at maybe, is there a possibility of doing a computerized screening, brief intervention, and referral to treatment services? Now this is kind of a busy model, but it is our kind of a conceptual framework that we've been working with to kind of look at the big picture of the problem. And let me just kind of go over this way. So this is, over here is we're looking at this endemic of violence, trauma, drugs, and recidivism. And what we really need to invest in, the shortest area, thank you, the shortest area over here is really, we don't have prevention models. We spend so much more money on treatment than prevention. There's some great community mobilization interventions that are coming out of Africa now that have had significant impact on reducing both all types of violence as well as HIV. And also there's some now on college campuses, bystander interventions, community level interventions that have also been effective in addressing IPV. Why don't we have these in our neighborhoods here? I mean, I think we need to think about potential models that can be used. And these are the most cost-effective ones. Then there are also, of course, legislation, policy, and advocacy to redress IPV. That's very important. So if we are moving then towards screening models where we can begin to identify women, men who are at risk of IPV that could be used in probation settings or other community supervision settings, we have IPV screening, brief intervention, and referral models. PTSD, trauma, I think trauma is very important to pick up because it does tell us what kind of intervention is needed. And then also substance use disorder screening and treatment referrals. And there have been very effective models of substance use SBIRT models, and I understand there's also effective computerized models for this. So depending on how these people screen out, then we can go towards more secondary and tertiary treatment models, which would include IPV interventions if they're only presenting IPV, trauma-informed IPV interventions if they have both IPV and an extensive history of trauma, and integrated IPV and substance use disorder treatment interventions if they're positive for both IPV and substance use disorder, and then trauma-informed substance use disorder treatment if they're positive for trauma and substance use disorders. Whoops, sorry. I shouldn't be moving around here too much. So this is something from our late great commissioner of health, who is now at CDC. We lost him. But he came up with this public health action pyramid. It's like if you have scarce resources, which $79 million for the entire United States, I would say, is fairly scarce, is where do we have the biggest population impact? Well, the biggest population impact is if we can really address the structural drivers of IPV. The second biggest, I would say, is if we can go more towards developing the community-based prevention models. We're going to have a deeper impact on the population. And then the SBIRT models, and then IPV interventions. So at this level, we have the highest individual impact, but the lowest population impact. So what we're really trying to do, I think we really need to build out on this side of the pyramid to have a deeper penetration on this issue. Okay, now I'm carrying too many things. Okay. Uh-oh. Matt. Sorry. Okay. Wait. Sorry. Oh, here we go. I wanted to start presenting some of our work. We are still at that top end of the pyramid. So I'm going to present some of our work that's dealt with a screening, brief intervention, referral to treatment model, some of our research, and then some that is more the interventions, IPV interventions that we're starting to develop. And I'd really like to thank some of our team here, Don Goddard and Stacy Shaw, as well as Tina, who has helped come up with this bibliography. And I have to really, really thank, a special thanks to all those of you in probation who made this study possible, as well as the Center for Court Innovation. Really, you've been fabulous, fabulous collaborators, and we couldn't have done it without you. And many of you were on our WINGS Community Collaborative Board. The goal of WINGS, which is a NIDA-funded study, was to develop and test a computerized, self-paced IPV SBIRT service model for community supervision settings, and then to compare the effectiveness of a computerized tool versus the same SBIRT tool delivered by a case manager. So what we wanted to know, is it more effective delivered by a computer or by a case manager? And so what we did for the trial, we enrolled 191 women from probation and community court sites in New York City. They completed a pre-intervention assessment. We randomized women to 2 different conditions, the computerized WINGS, which WINGS stands for Women Initiating New Goals of Safety, and or the case manager WINGS. And 171, or 90%, completed a 3-month post-intervention assessment. So the core elements of WINGS follow like your standard brief intervention model for IPV. We do brief psychoeducation about IPV, raise awareness about the connections between IPV and substance use. We screen for different types of IPV and provide individualized feedback. We elicit motivation to address IPV and relationship conflict using motivational interviewing. We do safety planning, social support enhancement, goal setting to improve relationship safety and reduce IPV. And then we identify substance use and IPV service needs and linkage to IPV and other services. So this is what it looks like when women log in. So it's completely self-paced. There's an audio track to it. We had a narrator that the content came from a lot of, we had community consultants, many of whom were formerly on probation themselves, as well as some of the probation providers helped us out with this. And so we also had women share their stories we had a great access to a documentary, and Virginia was one of our featured guests on the documentary, sharing their stories about what did violence experience look like for them. And these narratives were so powerful. We had folks crying sometimes at the computer when they listened to it. They were like, that's me. This is what you know. So the great thing is with these computerized tools is you can actually bring these stories in. And so we did a standardized screening for IPV, we did safety planning in it, we did a social support map enhancement exercise, steps to increase social support, so a lot of goal setting about what they wanted to do about relationship abuse, and then helping them to think what steps they can take, what kind of services they need to address it, and then referral to organizations. Now let me just say, it is a challenge to find organizations that we felt were really competent in addressing this issue among women with a triple risk of IPV, being under community supervision, and also using drugs, actively using drugs. There are very few sort of residential programs here that will take women who are experiencing violence and actively using drugs. That's a real resource gap. And so just to look at the socio-demographics, average age was 34, about 97% were either Black or Latina, 84% were unemployed. Let's remember that 2/3 had children. So what does that look like for them? What are we doing for those kids? 71% were single. And this is the other key thing that somewhat surprised us, but I 18% reported having female partners. So, I mean, that was like something we need to think about specialized, do we need to adjust? All these models have been mostly developed for heterosexual relationships. Do these work in same-sex relationships? I think that's a big question. So what are the results that we found? Well, interestingly, between the case manager and the computer condition, those who reported any physical, sexual, psychological, or severe verbal IPV in the past year, 77% for both conditions. So it's virtually identical. If we looked at any physical or sexual IPV right here in the past year, 47%. Now these are off the charts high for a substance using population. This is a very, very high rate. And so we're really getting to a concentrated epidemic here, I think. So in terms of some of the outcomes, we didn't see any difference between the computerized or the case manager condition on any of the outcomes at 3 months follow-up. But what we did see is in each arm, they significantly improved from baseline to the 3-month follow-up in terms of linkage to IPV services. They were more likely to be receiving IPV services at the 3-month follow-up, reported higher levels of IPV self-efficacy, which means their confidence and ability to control their risks for IPV, increased social support, significantly increased social support from baseline to the 3-month follow-up, and also increased the number of days of not using drugs. So we were very happy with these outcomes in terms of saying that both these modalities work. Did it in 44 minutes. For 44 minutes for the computerized wings, 46 minutes for the case manager. It's a doable intervention. No adverse events were detected, and we had pretty high rates of people who said they were very satisfied, 88% for the computerized wings, 84% for the case management wings. So some of the limitations, we had no control group, so we don't know if they would have gotten better anyways without this intervention. I think there's huge ethical considerations of if we did put in a control group. It's hard with a life-saving intervention like IPV. And we didn't address the perpetration of IPV. I do think that's a limitation, something we can address in future models. No longer-term follow-up of outcomes. We don't know if they sustain these outcomes. And we didn't measure IPV as an outcome in order not to bias the screening of the IPV. So in terms of conclusions and future directions, the outcomes suggest the feasibility, safety, and effectiveness of both modalities for identifying and linking women to IPV services, the lower cost of the computerized, self-paced condition and less staff burden make it more scalable. How many more problems can probation take on in terms of screening and servicing? You're already dealing with so much, and is there a way that we can start thinking about more cost-efficient models? So the other thing I just want to talk about as we go into that zone of just IPV interventions for people who have already been identified as experiencing some IPV or substance use, which this population is. We had recently completed a large-scale randomized control trial that was funded by NIDA that tested a 4-session group-based intervention, which is an integrated IPV and HIV intervention that also address substance use risks. and it was compared to a 4-session wellness promotion control group. We actually had compared 2 modalities of delivering worth, which was, one was a multimedia version and one was a traditional group. And worth is really a sort of an evidence-based behavioral intervention guided by social cognitive theory that focuses on problem solving and communication skills to negotiate safer sex practices, safer drug use, safety planning to avoid IPV, goal setting, and linkage to IPV services. So just to go through it, they're very similar sociodemographics to WINGS, but I want to point out these 2 things at the end. 13% of the women tested positive for HIV. That is a rate comparable to sub-Saharan Africa. And among African American women, it was like 18%, closer to 18%. That's huge. That's huge. We're getting to another concentrated epidemic here that's all within the same thing. And folks who are HIV positive are much more likely to experience also IPV. And then we also found that 30% tested positive for a sexually transmitted infection, which also increases their risk for HIV. So in terms of the findings, we had some promising findings in terms of, we didn't find any difference between the computerized or traditional models, same thing like WINGS. But what we did find is we compared both active arms of worth to a wellness promotional control arm. We found a 49% reduction in the number of unprotected acts that worth was effective in achieving, and also a 68% lower odds of experiencing any type of severe IPV. So at the 12-month follow-up. So we were very happy with these findings. The next step here is we were funded this past year to come up with a totally computerized self-paced module of worth that can be, and we're focusing on African American women just because of their extraordinary risk for HIV, seeing if we can come up with a more culturally tailored intervention that can address their risks. We're working with Fortune Society and very delighted, and Probation on this study. The other one, PACT, it's a different PACT, Protect and Connect. We were funded by NIDA, which we are in the middle of, and that is a couple-based HIV and IPV intervention, and it addresses the triple risks of HIV, drug use, and IPV by improving couple communication skills and relationship safety. And to date, we've enrolled 145 couples into the study, and it's scheduled to be completed in 2017. If you have any questions, you can ask Don Goddard, our project director, who's taken that one over. And so just in terms of next steps, where do we go from here? We need to advance a cross-cutting partnership with key stakeholders, and I really think a lot of them are here right now in this room. We need folks who are doing community supervision providers, folks affected by these problems, community leaders in these communities heavily impacted by them, to really come up and develop and implement a longer-term strategy to address IPV in community supervision settings. We really need those community prevention models, I think, as well as a whole range of other multi-level interventions. And we have an urgent need, I think, to develop or adapt interventions for adolescents and young adults. They are much more likely to experience IPV, and we also need ones specifically developed for the LGBTQ community. There's a huge dearth of research on both of these issues, and we also need, for all types of research, epidemiological intervention and implementation research on IPV among community supervision settings. Thank you very much. Yeah.
Thank you, Dr. Gilbert. I have one more very important acknowledgement that I neglected to mention before. We're honored here to have Commissioner Rose Pierre-Louis from the Mayor's Office to Combat Domestic Violence, a very important partner in this work, and she has been leading all sorts of efforts, actually, now that you mentioned this community-based initiatives, and hopefully we'll get a little something from those later. But thank you so much for being here, and thank you for your support and for being a partner. I think we have a road trip to Rhode Island pretty soon. So anyway, let me now pass it along to Brenda Davis from Probation.
Good morning, everyone. As Commissioner Bermudez said, my name is Brenda Davis, and I'm employed with the New York City Department of Probation. I'm the branch chief for the South Bronx NEON, which is the acronym for Neighborhood Employment Opportunity Network. I'm very happy to be here as a representative of the Department of Probation, and the common denominator here is intimate partner violence. Intimate partner violence is a growing epidemic in New York City, and any opportunity to partner with other agencies and programs only strengthens our skills, abilities, and resources when dealing with this issue. Our perspective is somewhat different from Ms. Gilbert's. However, our principal goal is the same: victim safety. New York City Department of Probation partnered with Safe Horizons, the Bronx District Attorney's Office, about 9 years ago to address an increased number of domestic incident reports in Bronx County. And this was as far back as 2005. This was the birth of the PAT Domestic Violence Program, which started out as a grant-funded program. The funding has ceased, but the program continues. The goal or mission of the PAT DV program is to hold the offender accountable while keeping the victim safe. The program mandates that any client who is convicted of a felony or misdemeanor offense, DV offense, moreover, any client who was named in a domestic incident report, intimate partner situation, is required to attend 12 weeks of educational domestic violence classes, which are run by probation officers who were trained by Safe Horizons, who also created the curriculum to facilitate groups. Once the clients complete the 12 weeks of group, they are stepped down, and the probation officers attempt to refer the clients to a 26-week domestic violence program within the community. This is sometimes a challenge because first of all, if our clients are unemployed, they can't afford to pay a fee for a program in the community. And another situation that occurs is that if they resist and they refuse to go to the program, sometimes the judges, if they haven't had a sentence of domestic violence, they weren't convicted, their probation case isn't a domestic violence sentence, but because they had multiple DIR, we put them in the program. The judges sometimes refuse to enforce the 26-week program. And what we've done to resolve that issue is that we just have them go through our program for a second period. PAT staff is required to reach out to all victims if the victim information is available. The PO contact information is given, and they provide safety planning information by referring victims to the Family Justice Centers and Safe Horizon. The PAT DV probation officers are extremely innovative, and they have an out-of-the-box approach to introducing information to the clients. They don't just have them sign in and hand them pamphlets. The clients have attended several productions by theater groups such as the Maria Project, Thespian Productions, the Theater of the Oppressed. And each production had some aspect of domestic violence, and more importantly, some form of oppression. Of 14 to 24, who uses their own personal stories, use their own personal stories to create scenes, have performed as part of groups, as a part of the groups. Addressing issues as domestic violence, such as domestic violence, race relations, rape, and etc. We have invited victims of domestic violence to tell their stories as a part of the group forum. One such victim was Quasana Cobbs, who shared her story on the Last October, a town hall meeting was held at our South Bronx Neon location during Domestic Violence Month, and the focus of the event was how domestic violence abuse impacts the community. Clients, staff, and community were present, and probation was able to bring awareness to the subject. The mayor had just announced his Upstander campaign, and everyone, Upstander campaign, which basically states everyone plays a role in preventing intimate partner violence. And we shared it. There are 5 ways to be an upstander. 1, you recognize and speak out against intimate partner violence. 2, you speak up when you hear jokes or other statements that promote violence. 3, you offer unconditional support for someone who has experienced violence. 4, you get help from an expert, advocate, or other professionals. And 5, which is most important, you give appropriate resources. Call the New York City DV hotline. In any emergency, call 911. For information and referrals for services, call 311 and ask for the nearest Family Justice Center. I could talk all day about PAT and the hard work that our officers put in to hone their skills by attending conferences, seminars, listening on webinars to bring an effective message to our clients. But that's not the main focus here. Although it would be remiss for me not to acknowledge that the PAT staff is here in the audience, and if you have any questions, you can defer them to them, because they are the experts. They're the ones who run the groups, and they know specifically what the responses are from our clients when they're giving them the information around this subject. The choice to stop abuse has to come from the abuser. And while we hope abusive partners will change, it is not always realistic to expect that they will. However, I would just like to point out that although many of our clients do incur rearrests, for the most part, the rearrests are not DV related. It's extremely important that we continue to shine a light on this issue for both the abuser and the victim. One, for the abuser, because you don't want them to continue to perpetrate this behavior, and it's passed down from one generation to the other. The victim, absolutely, because we have to empower them and help them to, and direct them to a safety planning situation. If I had one wish, it would be that there would be no more victims. However, statistics tell us that this issue has been around for thousands of years, and unfortunately, here now in 2015, it continues to grow. Wishing alone is not enough. We have to be upstanders, bringing awareness to this issue, collaborating and looking for solutions. While attending a VAWA meeting at the Family Justice Center a couple of days ago, I saw hand-painted T-shirts created by the victims of domestic violence hanging in the lobby. And each shirt contained a personal message, such as, "You took my light, broke my spirit. I have no voice, silent no more, found my joy. Love is blind, but now I see." And the most profound message was being thankful for finding support. They felt that someone is now shining a light on this. And I have to commend the mayor's office, because Mayor de Blasio has shined a light on this situation. NYCHA domestic violence response teams are now in the housing projects where there's a rise in intimate partner violence. Mayor de Blasio had an initiative in October with regard to the Upstander campaign. And also there's a light shining in the Bronx. Senator Jeff Klein of the Bronx Borough President's Office, Ruben Diaz Jr., and the Bronx Chamber of Commerce launched the Bronx Hire back in October, where this is a job training initiative for domestic violence survivors. It's a job readiness internship program where this would lead to domestic violence victims to a path to financial independence. And there's a child care, paid child care as a part of this initiative, internship program. So that's empowerment, and that's what these victims need. That's the key. We, the community, must now focus on keeping the victims safe, not only focus on keeping them safe, but empowering the victim. And that's as important as keeping them safe. Thank you.
Good morning, everyone. So I'm going to be speaking about intimate partner violence in the LGBTQ community, and specifically among youth. So I'm really glad that Louisa already brought up that there's a real urgent need to talk about these communities. So my name is Aruna Krishnakumar, and I'm a supervising counselor at the Hetrick Martin Institute. The Hetrick Martin Institute is the oldest and largest nonprofit agency serving LGBTQ youth, and we've been doing it for about 36 years. So we serve youth ages 13 to 24 from all the boroughs, and we also have a location in Newark, New Jersey. Our mission is that all young people, regardless of sexual orientation or identity, deserve a safe and supportive environment. So a bit of demographic information. The youth we work with, 98% are youth of color, primarily African American and Latino, and 80% are living at or below the poverty line. So we have a range of services, academic enrichment programs, arts and culture, and I'm going to be really speaking about our counseling services, which I supervise. We have a range of support groups, family, individual, couples counseling, and they're all free. We don't take insurance. All our services are voluntary, but we do have quite a few mandated clients through alternative to incarceration programs, and currently, thanks to Rebecca, we are working with the Department of Probation to streamline referrals for clients who have been involved in the criminal justice system or juvenile justice systems. So we receive a lot of referrals from different community supervision programs, and it's currently because there are no diversion programs for LGBTQ individuals, and definitely none for LGBTQ youth. So I'm just going to give you a little overview on why this is part of the epidemic of intimate partner violence. So 21% of men and 35% of women living in same-sex partner relationships have experienced intimate partner violence, specifically physical violence, and that's compared to 7% for men and 20% of women who are in opposite sex relationships. So it's much, much higher. Transgender individuals have had an incidence of 35% intimate partner violence over a lifetime. So according to a 2013 report on intimate partner violence, about 36% of these survivors are between 19 and 29, which is the highest percentage in any age bracket. There's also a large number of IPV-related homicides among the LGBT community. Last year alone, there were 21 reported, which marks an increase as compared to 19 in 2012 and only 6 in 2010. 30% of survivors of intimate partner violence were HIV positive. In terms of specific populations within this, the highest rates are among youth and trans women. So transgender survivors were more likely to face physical violence and discrimination due to IPV, and were more likely to experience IPV in public spaces. They're also 1.9 times more likely to experience physical violence and 3.9 times more likely to experience discrimination. In addition, they're 2 times more likely to experience any incidents of violence just in the community. Young LGBTQ survivors, so up to the age of 24, were more likely to experience sexual violence within an IPV relationship, and the percentages are about 2 times more than a heterosexual relationship. So one of the biggest issues that we're finding is reporting to the police, and also police-related violence. Over 55% of LGBTQ identified individuals are denied orders of protection. Half of LGBT survivors cannot access shelter safety, and a fourth are mistakenly arrested as the aggressor by law enforcement. In 2013, 17% of total survivors reported that they had applied for orders of protection, which is a huge increase, but that still means that 55% are being denied. We also need to really look at the disproportionate rate of LGBTQ youth involvement in law enforcement. So the LGBTQ youth represent about 15% of the total juvenile justice population, and they only make about 5 to 7% of the national population. So they are way overrepresented in the juvenile justice system. So the work we do at HMI is really to provide services where we see there are gaps. Our approach combines a trauma-informed care approach with positive youth development, and we're really trying to use individual interventions combined with prevention models. So like as Louisa was saying, we feel that one of the most important things to do is raise a generation of upstanders and of young people who are able to identify what violence looks like in their lives. The young people we work with face a range of issues, including homelessness, family rejection, sexual violence, physical violence, and bullying. And within intimate partner violence, there are specific dynamics in this community, such as power dynamics around age, housing, sex work, isolation due to gender identity, sexuality, and HIV status. One of the most unique challenges that we face is seeing dynamics of being outed to family members and workplace. So that's something that we're really trying to work around, especially disclosure around HIV status. So we try to tie together a holistic approach to meet young people's needs and support them to make informed decisions around their well-being, especially around relationships. We have a violence prevention program, which is in the form of a community meeting, where monthly young people can come and bring up any issues of violence that they're seeing in their communities. So we try to combine it with conversations about healthy relationships, but also violence just generally in the community. We also train peer educators to go out into the community and do programs in schools, in other community settings around LGBTQ youth, specifically around bullying and healthy relationships. And we have an evidence-based intervention called Be Proud, Be Responsible. In terms of, I think, this dichotomy that we're often talking about in terms of the victim versus perpetrator, I think we really want to expand that understanding, because what we see in intimate partner violence relationships with youth is that often there are enactments and reenactments of violence, whether it's interpersonal, family, or community violence, and also witnessing violence at a very young age. Young people often identify with the aggressor in their lives, and the work that we do in counseling is to try and find other mechanisms of coping with their traumatic histories. We also see that the long-term effects are often impacting their self-worth and self-efficacy, which also manifests itself in protracted depression, anxiety, high rates of substance use, high levels of high-risk sexual behaviors as well. So in our work, we're trying to look at this and look at the intersections of young people's identities in terms of race, ethnicity, gender expression, gender identity, and sexuality, and understand the ways in which they make decisions around their relationships. So as has been said, there's a huge gap right now in terms of prevention models and treatment models for young people, and I think that's really where we want to start. So I'd like to open up that conversation more. Thank you.
Good morning, everyone. My name is Virginia Nepper, and I'm the Senior Director over at the Fortune Society, and I just want to give a little bit of a history about myself. As Louisa was saying before, I at times have a problem with language that's actually used, talking about people as perpetrators, as victims, etc. For me, I see myself as being a survivor. For 17 years, I was labeled as a victim, and I wound up taking my abuser's life. And I wound up becoming incarcerated, and I did time upstate, and I did a substantial amount of time. During that time while I was upstate, I was receiving therapy, and we realized among a group of us ladies that there was no program that was actually working for us in terms of talking about the histories of violence that we had all had. So back in 1985, we did a piece where we had 12 women, and we testified to a bunch of commissioners, to judges, to lawyers, asking for a program to be instituted within the female correctional facilities. And lo and behold, we were very fortunate where we actually got a program that was entitled the Family Violence Program. That program started in Bedford Hills. We had the Westchester Coalition that came in, and they actually trained us as peers to do workshops to help other people that were also survivors of domestic violence. Moving forward, 17 years later, I was released, and I started working at the Women's Prison Association, which then at the time was under the direction of Ann Jacobs. And from there, I then moved over to working with the Fortune Society. What I have found recently for myself at the Fortune Society is that it is very intergenerational. We have, in the Fortune Society, most of our demographics, we have more males than we have females. But what I'm finding is with our younger male population, they feel that when they're exercising their authority or trying to show that they're the one that is the higher individual, they're not acknowledging the fact that they themselves are victims of violence that they're actually seeing in their homes. I have to say that I agree with that. There are certain areas, the low economic areas, as well as also educational pieces that come into factor with individuals that are victims of, again, victims, that are survivors of intimate partner violence. What I have found is that here in Long Island City at the Fortune Society, we have several evidence-based programs that actually directly talk to self-esteem, your self-worth, what you can do for yourself as an individual. If you've been incarcerated, you also then become subjected to pieces of abuse within the system itself. It's another system. You go from one system of abuse into another system of abuse. So you really don't have that opportunity to take the time to look and see where the correlations are even between the two. I know for me, it took me a while to realize that I went from one form of abuse to another system of abuse at that point. Even though I've relinquished myself from the intimate partner violence that I now had a systemic abuse that I was now facing. I was being told when to get up, when to wash, when to do this. You had certain times for line calls, etc. All those type of things while you're inside a correctional facility. One of the things that I have to say with the Fortune Society is during the month of October, which is Domestic Violence Month, we actually had a woman come in, and she spoke to the staff, and she also spoke to our clients, and she gave a little bit of a history about her own history of domestic violence. And it was well received by everybody. She received several questions naturally from the audience and on that order. During the month of March, which is Women's Month, we actually did a survey. And in our groups, what we did is we went around asking all of our participants in there who they had as role models, and a lot of them said that they had their mothers, their grandmothers that they looked up to. And at the same time, they also spoke, though, about the violence that they see that's going on in their household. And because their parents were able to survive that violence, that was actually a very strong precursor for them in justifying or saying, or even determining, I should say, that their mother, their grandmother, because they were a survivor of that domestic violence, that they looked up to them for just that. We then took it a step further and asked them that if you yourself are a survivor of domestic violence, because there are some young men and some young women within the Fortune Society that do have that that mechanism in terms of being a survivor for domestic violence, do they see themselves as that, or do they see it as a coping mechanism for themselves? And a lot of them actually just see it as a coping mechanism that they don't know any other way because that's what they were brought up with. That's what they've seen all their life, so they've internalized it, and they feel that that's the right way. And to be perfectly honest with you, when I think about that, when I hear that coming from the young individuals that we have in our programs, it brought me back to a little bit about what my life was like, as well as also my husband's life. My husband was the victim of violence in his household, and his father was the victim of violence in his father's household. So you've got a generational pact that's actually coming. So when you take these low-income areas, or you take individuals that have not been afforded an opportunity to get the type of education that they need, so that it takes them out of one area and brings them into another area, they're going to continue to breed what they actually see because they don't know anything else. We've just recently had some young men that had an opportunity to go to Bennington, Vermont, and they spent the night in the college. And these are young men. I think they were between the ages of like 19 through 22. They have never been away from home. You take them up to Bennington, Vermont, they go to the college, and it was like a totally different way of life for them. They come back, and chatter about it is still now going on, and they had an opportunity. They toured the college, they saw what their capabilities are, and this is in an area for them which they would have never had that opportunity had they not been given that opportunity. Most of them don't even know. If you live in the Bronx, most of them will turn around and say, you know what, I've never even been down to Brooklyn at this point. I'm just so stuck and rooted in the area where I'm at. But what I do want to say is I want to give you some stats on some statistics for women who are actually within the walls of the correctional facilities. You will find that 75% of the women that are currently incarcerated have endured some severe form of intimate partner violence. The crazy part about it is that even though they've had the intimate partner violence, there are other pieces for them in terms of their own well-being, their own physical health, that they may not have realized play a very large part with it. You'll find from time to time when you talk to someone who is a survivor of intimate partner violence, that they, in the beginning, start to get real bad headaches, they lose their concentration. If they're a heavy smoker, you'll see that asthma develops on them a lot more earlier. You will see that some of them have actually turned to substance abuse because they found it as a way of coping, even though it doesn't make the violence go away. For them at that point in time, it just tones it down for them, and it mitigates it for them. It makes it lesser. It makes it appear for them that it's lesser than what it actually is. It also increases the vulnerability for them to become HIV positive or to have another form of an STD. It also brings on the possibility that you take the risk of having diabetes, because a lot of us at times when we're stressed out, we have the tendency to eat food that's not good for us. And if you take in that food that really is not very good for you, you'll find that that winds up happening. 93% of the women who are incarcerated in New York for killing an intimate partner have been abused by another person. It may not be the partner that they've actually killed, but somewhere along their line, again, it goes back to the generational pieces that there has been some form of abuse that's been in it. When I talk about systemic abuse, when you become incarcerated, you become subjected to body searches, and those body searches for you can be quite physical. It could really become it will become very traumatizing for you. Not that it can't, it will. You wind up being shackled, you have handcuffs, there are times where you have restraints. There's a possibility that you could be put into solitary confinement, because if you're having some sort of a backflash of what's transpired, you may lash out at somebody and not even realize that you're lashing out. So you then become part of solitary confinement. And when you actually realize you're in solitary confinement, you're wondering what you've actually done wrong, because you don't remember what actually transpired from it. The overwhelming majority of women that are in prison, they are all survivors of some form of domestic violence. 3/4 of us have histories of severe physical abuse. I was also glad to hear that Louisa also started to include the financial and the economic pieces behind it. There are a lot of women that are incarcerated that if they were working as I was working, and I use that as a form for myself as taking myself out of the situation, didn't realize that I was strong enough to remove myself entirely from the situation, that economic abuse plays a very large factor in there. Emotional abuse plays a large factor in there. Sexual abuse really plays an awful lot, a large factor in there. Rape, assault, all those pieces. 82% of us had suffered some form of physical abuse, and close to 75% of the women inside have actually reported having sexual abuse as a child. At Fortune, what we attempt to do, and I say attempt to do because I feel very strongly that in order for an individual to move on to another stage, they have to want it, and it's very hard to get a person from being stuck in one area to move them on to another area. A lot of what we do is I see my staff working with them very, very closely, having discussions with them about pieces that are going on in their life and what's life like for you after you leave here during the program, during the day. There are quite a few individuals that come to me and they'll tell me that they'll stay late at night because they don't want to go back to their neighborhood. They don't want to go back to their households. So in ending, I think what I would like to say is that it is really important that the work that we do, that besides just looking at the individual, we really have to look at the total social environment that encompasses that individual. It really plays a very strong part.
Okay, so good morning, everybody. I'm sort of the odd duck out here because I'm going to talk to you about science. Aren't you excited? Yeah? Okay, so I'm going to start with a few questions. And the questions for me have shaped my whole professional career that led me into science as a way of having a particular lens about our human condition and our communities that has made all the difference in my work. And so I'm going to share some of that. And when Anne asked me to be on the panel, she asked me specifically to comment on what other people had said from the lens of neuroscience. So I'm going to be doing that with you. But first, the questions. So what if? These are what if questions. What if we could equip people with the ability to be better advocates for themselves? And what if we could enhance their engagement as citizens in their own behalf? And then third, what if we could increase resilience in communities where people live in poverty without increasing their dependence on systems they have no control over? That's a big one, right? And so I'm going to draw you a little map of your nervous system. And what we call the resilience zone. And the neuroscience model that I work with focuses on the autonomic nervous system. How many of you just love science when you were growing up? Not very many, right? All right, so I'm going to try to make this palatable to you, and I'm only going to take a minute because I only have 10. Okay. So the nervous system means your brain and your body. That's all it is. But like everything in nature, our bodies have these rhythms and cycles. And the one inside are your nervous system. So that's your nervous system here when you're in your resilience zone. And it looks like this. So that there's a rise and fall of excitation, activation, and calming. It goes on all the time. And when that rhythm looks like this, you're in what we call the resilient zone, and what it means is that you're thinking, you're feeling, and you're sensing. All the different systems of experiencing life are congruent. They're all working together in your behalf. Now, unfortunately, what happens for many of us, and certainly for many of the people we're talking about, who go into our systems of support, zone, an event happens, or a series of events happen, or a trigger for an old event that brings back everything as if it's happening right in the moment. And instead of having this gentle rhythm of the resilient zone, what happens is the rhythm gets out of whack. That's the scientific term for it, out of whack. And when people are out of whack, they either get stuck on high or they get stuck on low. And a couple of years ago, so this model of nervous system functioning is not it's just something that we know now, and we know for sure now because we have so many sophisticated diagnostic ways of looking at the way the mind-body works that we're not just guessing. And this body of knowledge from neuroscience has a lot, it can contribute a lot to the way we think about people who come to the attention of corrections in one way or another. It can say a lot about just about any of us, frankly. So here's what happens for people when they get bumped out of that zone, either by a single event or by a cumulative event. So it's a trauma model in a sense. We call it stress, distress, and trauma. So when you're stuck on high as an individual, you are irritable. It can go all the way to rage. It's an acting out process. You can be anxious. Pain is a sign of being stuck on high, of hyperarousal. Trying to think of some other ones. Anger, hostility, pain, those kinds of things. When you're stuck on low, on the other hand, you can be depressed, you can be exhausted, you can be dissociated, disconnected from the immediacy of your life. And the thing that we've been done, two years ago, we got a colleague and I got a fellowship from the Rockefeller Foundation to take this individual lens of neuroscience and expand it to larger systems like communities or like countries. And so then we can start to look at what happens to a community when it's in its resilient zone, when everything is working in a way that creates safety and builds trust and engagement for the people that are a part of that community. And what happens to our communities when they're in a state of hyperarousal or hypoarousal? Communities, and this can be a workplace, it can be a geographical community. In Rwanda, we're working at the country level. It's a small country, so we can do that. In a community that's stuck on high, we see instances of bullying and violence. When a community is stuck on low, we see disengagement at the community level, isolation of people in those communities. And so we can begin to design at the policy and program level policies and programs that attend to this kind of wild imbalance in a system. Because one of the things that we know is that a system, when it's out of balance, we're always seeking balance. And so if you're stuck on high, most likely at some point, where are you going to go? You're going to go to be stuck on low. And in the individual, in children, when we see that, we diagnose them with attention deficit disorder with hyperactivity, right? And then we give them medicine. And it's not that some children don't have ADHD. It's that children who've lived in a trauma-saturated environment, a community or a family, their system can look like this not because they have ADHD, right? And so, and with adults, what do we call them? When you swing up and down like that.
Bipolar.
We call them bipolar. And certainly bipolar disorder, I'm a psychologist, certainly bipolar disorder is a legitimate diagnosis, but there are people who aren't bipolar that are diagnosed with that because their nervous system is completely dysregulated. Okay, so that's the little science lesson. That wasn't too bad, was it? A little palatable even? The good news that comes out of neuroscience is that we have, let me just stand up so I can see people in the back. We have this amazing asset that we rarely use in many of our programming, which is called neuroplasticity. Have you heard about that wonderful thing? Because you have it. In fact, right now, you've probably added a whole pile of new neurons to your brain just by listening to these great presentations. So neuroplasticity is the capacity of the brain to change itself. And we used to think, you know, we were kind of stuck with the brain that we had by the time we were in our early 20s. Now we know that the brain can change itself until the day we die. And the way it changes itself is the key to our intervention, which is, what is it that you're paying attention to? So where your attention goes, this is a sports physiologist who says this, where your attention goes, energy flows, and that's what grows. So if you pay attention to everything you're terrified about, that's what you wire into your brain. If, on the other hand, you learn skills, and that's what we have, a set of skills that help people shift from this to this. And when you shift from this to this, you're capable of advocating for the things that you need. You're capable of problem solving, because what we know is that we have an old brain that has a new brain sitting on the top of it. And that when the going gets rough, the new brain goes offline, many aspects of it, and you can't problem solve. You can't think things through. Most of us have probably been in that situation, right? Where you're late to something and you can't find your keys anywhere, right? And the more frenzied you get, the worse it gets, not the better. That's because parts of our brain go off, our cognitive, our thinking brain, go offline when we get out of our resilient zone. So if we can teach people simple skills of how to get back in, they're capable of being their true selves. So I'm going to go through a few of the points that I highlighted from all these wonderful speakers and just make a couple of little comments about them. So the commissioner talked about a language problem, and it's pervasive. Mm-hmm. In our model, what we do is we shift the lens from pathology to biology, that there are reasons why people behave the way they do. And if we can, it doesn't excuse what they do. But in these states, you're not thinking clearly. And so if we try to teach somebody something when they're in one of these states, they won't remember anything that we said. Why? Because that part of the new brain is not working properly. So the language, like even the language, a violence program, mm-hmm. is, why not a resilience program, the family resilience program? Working in a hospital, they were doing a pain study on people who'd been in our group. This is a VA hospital with combat vets. And so the researcher said to me, well, we're going to have them collect a pain diary. I said, well, that's interesting. Where your attention goes, energy flows, and that's what grows. So if we're encouraging people to pay attention to their pain, what are we wiring in? A sensitivity to pain. So what about a diary that says, when didn't I have pain? Or when was my pain the least? So this is a shift in orientation that says and affects our intake interviews, for example. Let's just talk about that. So you interview people, and you have to, for the legalities of what's happened to them. Let's take a sex-trafficked teen. So we need to know about her tattoos. We need to know about rapes. We need to know about a lot of things in order to get justice for her. But if that's all we collect from her, pretty soon she's going to be out of the zone, most likely down here, because she goes into freeze. So in our intake interviews, just as a simple example, one of the ways we do it is we collect some activating information, and then we shift to calming information. So if we're interviewing her and we watch her arousal level increasing, we'll shift and we'll say, for example, if you had your best friend sitting here with you, and I asked your best friend, what are the things she likes best about you? What do you think she'd say? Because these girls, 11 years old, trafficked kids, won't talk about those things, those good things about themselves, and most people aren't interested because we're so problem-focused, right? So she tells you what her best friend would say, though, and you watch the calming effect because it's wired into us. One of the reasons we've been able to take our model around the world is because every human being on the planet is wired the same way for resilience and to respond to threat and fear. We're all wired that way. We may interpret the symptoms differently, but we're all wired the same way. And so now we know, through these wonders of neuroscience, we know another tool to put in the tool bag, which is self-regulation skills that help people when they start out of that zone to get back in. So one of the things that I was very excited to hear Louisa say, talking about computerized models, because we originally started with the low-tech version, which was we gave our pens out to people, and they have the skills on each side. Because people said, oh God, I forget how to use them, because the new brain, right, parts of it go offline. And so they said, you know, I need something that'll help me remember. So we made all these pens that told them how to go through the skills, right? But it was a little cumbersome, and eventually these things would break. Nobody had to know they had it. And then somebody funded, actually Gary Trudeau, if those of you who know Doonesbury, he funded an app for us called iChill. It's a free app. It has the self-regulation skills on it, along with these graphics. A voice will talk you through the skills, the non-clinical skills these are. So I'm a major believer in this whole idea of what can technology do. These e-health models that we're developing to take into Africa, where we can send learning modules into very remote places and equip people with skills like ours. Learning about the sympathetic and parasympathetic nervous systems fosters dignity, and it helps people then understand that when you're in the second trimester in utero, your hearing is 100% developed. And so if you're living in a chaotic environment, it means that your parasympathetic nervous system, which is extremely primitive in unborn and newborn children, it helps us breathe and digest food, but it doesn't know how to I can never say that word, self-soothe. Right. It's a hard one. It doesn't know how to do that. And so already before a child is born, they have a template, some children, of reactivity because of what they've heard in utero. Isn't that interesting?
So we're inching up to the
thank
border,
I'm
just to
down.
just to give you a time check.
Yep. So giving people information, training them in skills that anybody can use. Children can use the skills. So what do I have, like a minute or 30 seconds or none?
A minute would be fine, because actually you're accomplishing some of what I was supposed to accomplish, which is good.
Okay, I'll just, 2 more sentences then. So teaching in a public health orientation, equipping communities with these skills is a part of what reduces their dependence on the systems they have no control over. Because then they become the trainers for our set of skills, and they use them with their peers, in their families, in order to promote more people who know how to stay in the resilient zone, because when they're in there, there's more principled behavior, there's less violence, there's more collaboration. And then the last thing I'll say is about youth, because if you, those of you who work with youth and you haven't read Lawrence Steinberg's book, Age of Opportunity, he talks about, in neuroscience, he talks about this flood of sex hormones and the increased number of dopamine, which is the pleasure chemical in the brain, dopamine receptors, and that they come together in adolescence and have an amazing effect that isn't all that great for many of our youth, which is incredible and a search for intensity without much attention to the results, you know, the loss, the consequences. So we have to design our programs for kids in a way that has intensity. Ropes courses, things where they're really challenged in the outdoors. There are all kinds of ways to use these lessons from neuroscience lens, and that the more we use them and the more people learn how to pay attention in that way to their own mind-body system, we'll have more people and more communities that look like this than like this. Okay, so
Great. All right, so we're going to open it up to questions from the audience very soon. I just wanted to get one recommendation, I guess, from each of the panelists, if you would, around you know, promising interventions, in the sense of, you know, part of today was understanding the breadth of the issues, and I think these panelists, please give them another round of applause, because we have explored a great deal of the nuances of intimate partner violence. And so I would love to turn it now a little bit into the intervention piece, right? So now we have an understanding, now we need to intervene, and I call it interventions purposefully, because intervention is different than certainly prevention and programming, because intervention comes at the time where the harmful behavior is already happening. It's an interruption of the behavior, right? So what could we do in a community of, you know, we're in a corrections community ultimately here. What would you recommend would be a way to create new patterns of growth in the brain and in activities, so that we can start chipping away at the incidence of intimate partner violence and family violence? If you could each maybe like a minute to something as specific as you can that can be done, so that we can have something to go back with.
Oh, okay. I guess. Can you hear? So I'm thinking, I'm going back to the NEON model, because I think it's brilliant, and it's focusing on communities that have been heavily impacted by mass incarceration. And those are also communities that have been heavily impacted by family homicides, IPV, HIV. And can we build, first of all, and foremost, you know, jobs, the neighborhood, NEON, and maybe some of you guys can talk a little bit more about Neighborhood Employment Opportunity Network. We need jobs, we need community mobilization. Can we create that synergy that creates the happy communities that Lori was just talking about, that we can create that resilience? And can we also infuse it with different types of technology, social media? Pretty much everybody has a cell phone. There are apps out there. Can we also sort of take that synergy of leaders from different types of community, people who represent different factions in that community, to come together on this issue and really mobilize them to take ownership of this issue and to try to also advocate for resources into those communities? I know that's a little bit vague.
But essentially using the NEONs as a hub of
I think the
activity around
you
this,
already
in a
have
way,
the community collaborative
So you
boards
have
there.
that,
And to use those as a hub to do that. The other thing, I do think the specialized units within probation focusing on this issue, I think would also maybe help. So those are just two quick. Yeah.
I think the continued empowerment of the survivor. We do a lot of work with the, and now I'm afraid to say the word, batterer. Sorry. But I think the empowerment of the survivor is key, because we honestly can't control what someone else does, but the person who is the end result of that person's behavior has to be able to rise above that. And I think the focus has to be on empowering that person so that they can move out of that situation. There's some wonderful things going on, as I mentioned, with the Bronx Hire and some other things to work specifically with trying to put the survivor in a position where they can be self-sufficient financially, and working on other self-esteem issues and things like that to pull themselves out of those situations.
I think when we're talking about youth, Lori pointed out, something like a ropes course. I think we need really innovative programming for young people to get them engaged. We find that many of the young people who have experienced violence, one of our most popular programs is fencing. And it's always a surprise, but they love, the more active programming. And then you're able to engage them in conversations. So I think we need some innovative programming like that, as well as using social media, as Louisa said. So many young people are on dating apps, use Facebook, et cetera, and I think we need to really incorporate some lessons through using those for dating especially, and relationships. And then finally, I think one thing we haven't talked a lot is just the school to prison pipeline, and having interventions in schools where you can involve teachers, community members, and parents in these kinds of programming.
So everybody on the panel has really given some very good ideas with it, but I think I want to take those ideas and just say we need to bring it back to the neighborhoods that it's actually in. If we don't take it back to the neighborhoods, we're not going to be able to even start to do some of the work that really needs to get done. I think the NEON program, we actually have a satellite office up in the castle with Fortune Society. I think it's a wonderful piece, but I also think that we need to go back into the neighborhoods, and we need to work within the neighborhoods itself.
Yeah, I guess we're talking about two things. We're talking about how do we intervene when the problem has happened, and how do we prevent the problems from happening. And we need to have obviously both of those, but I'm with you on the community. There are so many things we can do in communities to create safety by weaving people together in constructive ways. And I'll put in a plug for the School of Visual Arts. Their students are creating games and apps for neighborhoods that help weave people together in these ways. So they'll take an apartment building and they'll ask people, they designed an app called Sugar. And it's, what are you willing to give to the people in your building? So if I own a hammer, you don't need to own a hammer because I'll loan you mine. And you weave relationships together so that people become known to each other for more than negative things. So it's something that weaves people together in relationship networks. We're born, we grow inside of another person. We have social brains. We have to construct our neighborhood processes in ways that enhance that.
Great, thanks. So there's a mic over here, and we'll take questions from the audience.
Hi, I'd like to talk to...
And please, if you can identify yourself and sort of
sure.
what your...
my name is Jill Clockadale, and I work for ASC NYC, which is a multi-service agency. I work specifically in a housing program, and we have people within the program who are both survivors and perpetrators, so we are looking at all these issues. I do have one question to ask.
Sure.
I do understand the whole zip code issue. When you look at zip codes and you see educational deficits and healthcare deficits and all of that, and increase in intimate partner violence. But isn't it true that as far as intimate partner violence as well as child abuse, Some of the other zip codes, it's not that it isn't a problem, it's just that it's not reported and it's treated much differently by the criminal justice system.
And obviously, I come from Columbia University, and we have a huge problem with sexual assault on campus, and they also come from, it's diverse backgrounds, but it's largely privileged. So I do think it cuts across classes, but the research shows that poverty is a major structural driver of intimate partner violence. I think it creates that stress in communities that Lori was talking about. The violence in communities creates it. The lack of jobs and opportunities is a huge stress factor for intimate partner violence. So I think there's structural drivers, but I want to be very careful to say that it absolutely does cut across classes. It doesn't, I mean, we obviously know the high profile cases of very wealthy people where it happens. DNA does play a role, genetic modeling does play a role, but they're highly stressed communities that are lacking jobs, and I think, and lacking sources of income, and are exposed to high rates of violence. So I think that makes them at higher risk. Yeah.
Good morning. My name is Erin Rogers. I'm a reentry coordinator with the Bureau of Prisons, and also a doctoral student here in criminal justice. My question is for Lori regarding your SRM curriculum. It says in your bio that it's been implemented already in corrections. We have a growing female population, so how does one go about being able to implement your curriculum within a correctional facility, and where would we get kind of the support and evidence to pitch it to our agency?
Yeah, we have a project in California that's about to spread to 25 prisons. And then Ann and I are trying to cook something up here in New York, and then we have this big project in Rwanda with where about 55,000 genocidaires are about to be released. So generally it takes, obviously, somebody at the higher up part of the prison system to give the stamp of approval. Interestingly enough, the first foray into at least a prison in New York State, the superintendent of that prison was more interested in corrections officers, which is another whole issue of reactivity. You talk about a system that's perfectly meshed in a negative way, is if both systems are reactive. So, it's about taking it in. It's very easy for prisoners to learn this. And then ideally what happens is a group of them, and this is what we're doing in California prison system, train people as trainers so that it's a peer-to-peer model that doesn't require, I mean, our whole goal is always not to become some outside expert, that comes in some position of hierarchy, but to take something in, give it away, and then people, again, to use the word dignity, can use it in the ways that they decide best. So I can talk to you more about that, the specifics. It does require, obviously, some approval at the upper levels.
Okay, thank you.
Okay, I'm giving my approval for applying it to probation.
All right.
No? I know this is not a shy crowd. Come on. I'm going to give the commissioner the last word, so.
And Lori, that was the best science class I've ever had. I wish you were my science professor. Just a couple of things. One, OCDV and probation, we are really looking at how we can collaborate together, understanding the realities around intimate partner violence. I think one of the great things about working in the de Blasio administration is that we are all charged to break down the silos, to work collaboratively together, but also understanding that each one of us as agency heads, commissioners, deputy mayors, directors, are also going to be charged at looking at issues, particularly of income inequality, through a gender equity lens, which I think is really exciting, right? So it's not just dealing with the IPV, you still have to deal with education, you still have to deal with workforce. But one of the stats, and you had said this early on, is that 24% of the city, of New York City's population is in neighborhoods characterized high poverty, high unemployment, low education attainment. They accounted for 42% of domestic violence homicides last year, right? So we're not using that information to marginalize, we're just using that information to know where we need to direct resources. So that when you're looking under an equity lens, you can't deal with income inequality and not understand that poverty disproportionately impacts women and not deal with IPV. And I think that's really exciting that we're going to be doing this in this administration. I want to thank Brenda for talking about all the initiatives OCDV is doing, because I do think the point is not everyone's going to walk into my family justice center, right, to get help. So you have to go where people are, right, to let them know about the services that we offer. We had 55,000 client visits to our family justice centers, which is great. I'd like to see it go higher. But the interesting thing, and we didn't talk about this today, is that 57% of that 55,000, 57% of our clients are foreign born. So that means that we need to think of really tailored strategies. So it's not just the African American community, it's the Black diaspora, it's the Hispanics, right? So that we develop interventions that are specific and culturally relevant to those communities. The last thing on youth, you know, a scary stat. How many of you have 11 and 12-year-olds? Only a couple of you. So scary stat, I came from a Haitian family, so I didn't start dating till I was 40, so I've only been dating for 11 years. But 75% of 11 and 12-year-olds in the United States are dating whatever that means to an 11 and 12-year-old. So we do recognize in the city of New York that we have to start sooner rather than later, because high school, you know, most of us thought we were grown by the time we were in high school. So it's important to understand that we need to talk to not only youth, but their parents, the custodian, the safety officers, the teachers, all of the folks that comprise that space where youth are at around this issue in terms of dating violence. And we, through OCDV, we have our Healthy Relationships Academy, which is a peer-led model that goes into schools and works with youth-based organizations and communities to talk not only to youth ages 11 to 24, but parents, right? So parents don't know about Snapchat, Twitter, Facebook, all of these things, because it's well documented what's happening in terms of cyber abuse and bullying, but we're not getting it on the dating. And I think the last thing, and what I really like about this panel, is that we're really touching on the third rail of IPV. And I think it's time that we do touch the third rail, because the reality is victims are choosing to stay, victims, survivors are choosing to stay in these relationships, right? So it's not about leaving all the time. They're choosing to stay, understanding that what tools and resources do we provide both of them that have experienced trauma to ensure that we can reduce recidivism, but that we can help them in being healthy, right? And their children's being healthy. So I think looking at the issue of trauma also is so important. Looking at the work of communities, we just received funding to do 2 community-based family justice centers that provide wraparound services for victims of domestic violence under one roof. One in the Bed-Stuy, East New York area, which is #1 for DV, and in northern Manhattan, where 75% of homicides and deaths, homicides and domestic incident reports happen. I would love to get the feedback of this panel on that. I know there's a neon also there. The last thing, though, in terms of we are doing something in New York City that's good, because in the first year of this administration, intimate partner homicides declined 25%. And I think that's because we are understanding about the collaboration piece. And And the one last thing I want to say is that we always use DIRs, domestic incident reports, to talk about this epidemic. Hi, Manny. To talk about this epidemic, and the Children's Aid Society is also doing really great work with families that are dealing with IPV, is that last year 282,000 domestic incident reports were filed by the NYPD. That's a good thing. That's not an epidemic, because DV still is underreported because we don't know who's coming through hospitals and other places, right? We want that number to climb. We want more people who want to get information and resources on how to deal with the violence that's happening in their lives to reach out for help. So that's not an indicator of an epidemic. That means through outreach, these conversations, more people are coming forward. So thank you so much to the panel. Anna, you rock, and thank you.